Hello again and welcome to part 4 of our lecture series on vascular ring anatomy. In this video, we will again be comparing two anatomic datasets. Both of these anatomies fall under the category of incomplete vascular rings. As shown here, we have the left arch with an aberrant right subclavian artery and the anomalous left pulmonary artery, which is also known as a vascular sling or the LPA sling. These anatomies demonstrate another example of how variably symptomatic vascular rings can be. First, let's review the left arch with an aberrant right subclavian artery. This variant arises when the right subclavian takes off from the descending aorta and travels posterior to the esophagus to reach the right arm. Again, we have maintained the same color scheme as in previous videos. As you can see in our model, there is an abnormal regression of the right fourth arch, which leaves the right subclavian attached directly to the descending aorta. In the uncommon scenario when there is a persistent right ductus, a complete vascular ring is formed, similar to a right arch with an aberrant left subclavian artery and a left PDA. However, more commonly, the right ductus generally regresses. Looking from a superior view, this does not form a complete vascular ring. Next, let's review the patient dataset. The posterior view shows the course of the aberrant right subclavian artery, as well as the potential for mild esophageal compression with this variant. The lateral view shows that there is not a complete vascular ring. This anatomy is one of the most common anatomic variants in the general population, with an incidence of approximately 0.5%. Although this variant is typically an isolated anomaly, it does have an association with coarctation of the aorta, as well as interrupted aortic arches, and it is present in 38% of patients with Down syndrome who already have congenital heart disease. Most cases are asymptomatic, although it can cause patients to present with mild feeding problems secondary to esophageal compression, often well into adulthood. Usually, no treatment is required for this lesion. Next, let's discuss the LPA sling. This lesion arises when the left pulmonary artery takes off from the right pulmonary artery, coursing in between the trachea and the esophagus to reach the left lung. Looking at the patient dataset from a right posterolateral view, you can see that the LPA courses in between the trachea and the esophagus, leading to significant tracheal compression. Moving to a superior view of the dataset, you can also see the LPA compressing the trachea, despite the fact that there is an incomplete vascular ring. In this dataset, we drew in the esophagus because it was collapsed down with nothing distending it. In this lesion, there is more significant compression of the trachea as compared to the esophagus, which explains the typical clinical presentation of this lesion, with patients more often having respiratory symptoms as compared to dysphagia or feeding difficulties. Although this is an incomplete ring, 2/3 of affected infants are symptomatic by 1 month, and they often present with severe respiratory symptoms, including coughing, wheezing, stridor, episodes of choking, cyanosis, or apnea. And as I mentioned, dysphagia is a much less common presenting symptom. Importantly, this lesion is associated with tracheobronchial anomalies, especially complete tracheal rings, which lead to tracheomalacia or tracheal stenosis. Complete cartilaginous tracheal rings are present in up to 50% of cases. It is also associated with GI or GU abnormalities, such as imperforate anus, Hirschsprung's, or biliary atresia. And 40 to 50% of patients also have associated cardiac defects, which can include PDAs, VSDs, ASDs, or even single ventricle anatomy. Treatment of this lesion involves surgical division of the anomalous LPA and reanastomosis with the MPA, along with potential airway interventions in the case that there are tracheobronchial anomalies. Interestingly, some surgeons transect the trachea to avoid transecting or reimplanting the LPA, although this is less common. Regardless, you can see from these two examples that while both are incomplete rings, these rings can vary substantially in how symptomatic patients typically are. With that, we will conclude our discussion here. We hope that you now feel more comfortable not only with diagnosing and differentiating vascular rings, but also with understanding the spatial relationships of the structures that cause these rings. Thanks for watching. I would like to acknowledge and thank my research mentor, Dr. Tannen, along with faculty that helped develop this curriculum, including Dr. Akimba, Dr. Rar, Dr. Paroli, and Dr. Mike Sekeller from University of Arizona, all of whom assisted in contributing content and revising this lecture.